Good afternoon, everybody. It is 2 o'clock, so we will make a start. And welcome to this, the third meeting of the West Yorkshire and Harrogate Health and Care Partnership Board. Once again, we're meeting in a council chamber, partly because that gives us the facilities to make it easiest to provide for members of the public to observe. And as before, the meeting is being live streamed on the partnership website and also recorded where it will be there. So I know council chambers can make for quite a formal setting sometime, but it's our partnership meeting. It belongs to all of us. I hope we'll try to make it as informal and approachable as possible. And we'll continue to try and work to make the papers as accessible as possible as well. I'd just like to say thank you to our colleagues from Bradford, and particularly to Councillor Doreen Lee, the Lord Mayor of Bradford, for allowing us to use the venue today. Since the last meeting of the Partnership Board, the West Yorkshire and Harrogate Partnership's Unpaid Carers programme has been awarded the Health Service Journal Award for system-led support for carers. I thought Rob was going to wave the award around. And obviously that's a good piece of recognition for the work of the programme. And our congratulations particularly to Karen Jackson, Richard Parry, Fatima Khan Shah and the wider team who have been involved in that work. As well as that, the Looking Out for Our Neighbours campaign has also been shortlisted for 3 industry awards. So congratulations to Karen Coleman and the team for that. And we look forward to the results. And we're launching phase 2 of that campaign on the 16th of December. So I hope people are aware of that and will continue to support this important campaign. Finally, in terms of the news, the partnership has established a shadow board to support the development of a group of aspiring leaders across the partnership. This group is chaired by Matt Walsh. They considered the partnership board papers yesterday, and I'm sure, where relevant, Matt may want to make sure their comments are fed in throughout the discussions. So just to make people aware that under the final item, any other business, I want to just provide an opportunity briefly to update on winter pressures funding and issues around that, which I'll ask Rob to outline where we are when we get there. On the second item, we would normally then now move to questions of public deputations. But obviously, as you'll appreciate, we're currently in a pre-election period in the run-up to the general election on 12th of December, what's known in the trade as PERDA. So we've looked fairly carefully at the advice to that, because that period does place restrictions on the use of public resources and communications activities for public bodies, civil servants, local government, etc. during the election campaign. So as a result of that, and in line with practice in a number of councils, we're not taking questions or statements from the public during the meeting. However, I know we have received some written questions, either by email or otherwise, both in advance and on the day. So I'll just ask Rachel to tell us what the topics of these are. We won't be answering these in the meeting, but we will be answering them in writing, posting our responses on the website and also including them in the notes of the meeting afterwards. So, Rachel, can you just advise what we've got?
As of 2 o'clock, we had 3 questions, one on the local industrial strategy, one on vascular services and one on unplanned care in the 5-year strategy. See if I got this right. So thank you very much to people who've put those in. As I say, we'll make sure you get written responses to those as quickly as possible. I'm sure you understand it's an issue with the timing of the election. Next item is to remind members of the rules surrounding declarations of interest. Just to remind people that we normally rely on the declarations that we'll all have made as individuals to our organisations, but if there is anything specific to the items on the agenda, I'd invite people to declare those as and when the issues arise. Item 3 is the minutes. The next item is the minutes from the meeting on the 3rd of September. These notes have been circulated. Can I ask Ian, first of all, if there are any items to update in terms of actions?
Thank you, Chair. So in terms of the actions, they're on page 12 and 13 of the minutes document. There's 4 actions Two of them are covered on the agenda today, so a further iteration of the 5-year strategy and the partnership's approach to co-production, communications and engagement. There's two items which we'll consider at a later meeting, which is around the distribution and use of the 8.75 million and reflecting on the way that we do public questions in the meeting, which is something that came out of the meeting in the summer. So two on the agenda and two for future meetings.
Okay, thank you. Are there any other points of accuracy or anything on the notes? Are we happy to agree those as a correct record? Everybody happy with those? Thank you. So our first substantive item is to look at the connections between health and growth and the draft local industrial strategy. I'm going to ask Kirsten England from Bradford and Tom Reardon from Leeds to introduce this. I'm not quite sure who's going first. Tom.
Thank you, Chair. And shall I stay sat down? Me and Kirsten are doing a double act here, and we don't know. We haven't rehearsed this, so I'll stay sat down because everyone else has. There's some slides as well, and we never use slides, me and Kirsten. So we've both been challenged by this new way of working. The industrial strategy is really designed to give a greater sense of priority around the economic planning in each part of the UK, and industrial strategy, by virtue of its name, was introduced a few years ago to try and make the economic plans of every part of the UK more distinctive and more coherent around the assets of their local areas. There had been a tendency in the past, in different iterations of strategies like this, to do what those of you remember TIPEX. Some of the younger ones won't know what that is, but it was before the backspace button and delete was invented. And you could sort of, if you change the name of a strategy, then it could be anywhere in the country, and they all tended to fall into the trap of being very similar rather than reflecting, as I say, the assets of the area. So industrial strategy is really aimed at putting that right, and the footprint for this is slightly different to the footprint of the health partnership, but it is near enough to make it very easy for us to link the two up. So it's the Leeds City region which brings in a slightly wider partnership moving out into Selby and York, but actually is very much the the same footprint as the one that we're operating in this partnership. And so there's been a lot of work to try and make sure that we link together the emerging economic strategy through the local enterprise partnership and the combined authority chaired by Councillor Hinchcliffe, and of which the leaders of most of the councils sit on, and the health strategy as well. So there are two slides that I'll do which are really trying to set a bit of context, and then Kirsten will go into a bit more detail about what it might mean for us in relation to health in particular. The big, just to explain this slide to you, the top of the slide is really the framework by which government and the national policy framework, obviously all subject to PERDA, but this is what we're working with at the moment, has set as what they call the grand challenges. So it's an attempt to look forward and to say, rather than the more traditional approach again, what are the big drivers of economic change globally that are going to change the world, if you like, and are going to mean that we're going to get lots of investment from an economic perspective going into them. And they are artificial intelligence and data, future mobility, and clean growth, and the ageing society. And they are, by their nature, very forward-looking, but also, in a sense, an opportunity for us to tap into, again, those assets that we have in the area. And the government would like, the national framework would like a sense of prioritisation around them. So they don't want everybody to pick all four of them. They want to concentrate on the things that you're really good at. And the other piece of work that we're doing at the moment in the city, in Leeds and in the city region, is a piece of work with the Massachusetts Institute of Technology based in Boston, which has a programme that they run once every couple of years with 8 city regions, cities across the world, where they look at innovation and economies and compare how you're doing and try and improve what you're doing. And they focus again on the same sort of idea where what are you really, really good at, what are you world class at in economic terms. And the really interesting thing from that piece of work, where we're working with Sydney and Oslo, Monterey, Guangzhou, is that health tech comes out as the #1 most significant and distinctive part of our economy in the city region. And not just a traditional view of health tech, which you might have thought about of, our great strength in making hip replacements and, and that tradition that we've had in this part of the world. But crucially, the way that health tech is applied to our population and the collaborative approach that we are taking. And so that brings in this partnership and the economic partnership really strongly. And it also brings in our partnerships with the private sector, with charity sector, the third sector and voluntary groups very, very strongly as well, because it's about how we apply these great assets that we've got to our local population for good. The middle bit is really the traditional, you'd find this in many strategies about what drives productivity, what are the big things that could change the way that our economy performs, and they are around the assets that we have, the people, obviously, and the skills base that we have, the business environment in which we operate, how we make it more, if you like, easy for businesses to thrive and to succeed, and then the ideas coming from the innovation that we have, and then, of course, infrastructure, transport, connectivity, etc., housing being very important as well. Along the bottom are some newer themes that you might not have seen if you'd have done this maybe 5 years ago, where the zero carbon economy, the climate emergency is something that's driving all of us to think differently, and that is a big factor. The inclusive growth agenda, where we are all, I think, in a position where we don't want growth at any cost. We want to make sure that everybody has the chance to connect in to a job, to achieve their potential, in whichever community they're in, wherever they grow up. And we know from the health inequalities that we have in our area that you can live within a mile of each other in some parts of our region, and you have a chance of living probably a decade longer in one part of our system than another. So big challenge for us. And then digital and tech and how that's transforming lives as well. So the second slide, my final slide, is you probably can't read that, but hopefully these were circulated, so I won't rely too much on the slide. But what this really does is come up with what we call they want a big idea. So our big idea really is what I described, which is how could we harness the really significant health assets that we have. When you think about the fact that we have the NHS based in this part of the world, we have the Department of Health based here, and the sort of agencies that revolve around them, they're all based in our region. We have some amazing teaching hospitals who do world-leading treatment of cancer, of heart disease, of many other health conditions. We have an amazing health economy and health businesses that have grown up around that, particularly around informatics and particularly around health tech. We have significant social care departments and of significant scale operating in this area and being very innovative around things like telehealth in this district, and also linking into research. The Born in Bradford is probably the best example of that, where we are, linking together the way that we're trying to develop policy with the people on the ground, and we have this right across the board. This very, we are a I describe West Yorkshire and This part of the world has been a very federal geography. So we're all trying to operate on this very community neighbourhood base to link up and make sure that all of this fantastic set of health assets affects and helps the people on the ground. We have brilliant universities doing brilliant research as well that links into all of this. So the things we're going to do, which I'll finish on, and before handing over to Kirsten, the things that we're planning are on ideas to work much more effectively, I think, with linking up our academics with our small businesses to try and drive much more success in this area and develop quite a strong brand around this health innovation for our part of the world to sort of stand out from the crowd nationally and even internationally. We are trying to develop our skill base. So on the International Day of Disability, it's a great time to be talking about the opportunity that we have to use technology, to use our collective endeavours to get more people with disabilities working actively in the workforce, being able to achieve their own potential, helping us achieve that extra productivity. And we have some really good ideas around skills. Councillor Hinchcliffe has led a piece of work around a skills commission, where basically what we would like is more devolution and more ability to tailor our skills support to meet the demand that's there in the system generally. And we think we can do that better locally than all these different national silos that do it at the moment. The business environment, we're keen to link up and make sure that we are working with employers to get people into jobs and create the right conditions on pay, paying the real living wage, making sure that people get the right conditions to be able to live healthy lives and to work effectively as well. On infrastructure, anybody who's travelled by train recently will know that we have a big challenge on that front, and we want, again, to get more control of how the trains run, whether our buses run right into our own communities, who are the ones suffering from the worst inequality, so we make it easier for them to get around, get the treatment that they need, but also get into jobs and the economy. And we have that connectivity as well. And then finally, on place, that we really link up and make sure that we have this very strong approach at the regional level, but equally each of our cities and our towns and rural areas are able to take advantage of this as well, and you know, play a part in what is a very important agenda. So the last thing I would say is that there was a time when I think it would have been harder to say that there was a strong link between this agenda and the local enterprise partnership and that economic agenda. But now there's almost an open goal for us really to take advantage of that in this development of this strategy. So I'll hand over to Kirsten.
Try again. Okay, thanks, Tom. So I think what Tom's described is a key shift in this iteration of the kind of economic strategy for the Leeds City region, and particularly to focus on the asset which the health economy represents in terms of commissioners, providers, academics, innovative businesses, the national and local institutions of the health economy that are represented here. So what I'm going to do is look at some of the specific opportunities that we might work on together across that overlap, if you like, and as well as preparing a local industrial strategy, making no assumptions about incoming governments. We hope to be also negotiating a devolution deal, and some of these would specifically be within our devolution agreement, where we would be looking for the greater flexibilities, freedoms and investment that Tom's spoken of. So the first one I want to talk about is described there as life-led, which I think is something you've discussed in your 5-year strategy, but it's really talking about the wider ecosystem for health and well-being, or variously described as the determinants of health, or looking at population health management. And as you all know better than I, only about 10 to 15% of people's health and well-being is attributable actually to health services, without diminishing the impact of the proper delivery of health services. It is also the case that 95% of all research that goes on around health and well-being is on the kind of treatment of acute and chronic conditions. Only 5% is actually dedicated to looking at the determinants of health. It's also true to say that most of that 95% of investment is spent between London, Cambridge and Oxford in what's called the Golden Triangle. And yet, the populations where some of the health is most challenged, the health status is most challenged, and some of the institutions doing some of the best work around research on preventative investment for health and well-being are actually located outside of that triangle. Now, this is a debate that is live within government at the moment, and they have indicated a willingness to readdress the balance of investment in terms of health research. And we want to take opportunity of that interest to push home the case for the investment in the north, in the Leeds City region, of an institute for research on preventive investment in health and wellbeing. It has been characterised as a Nightingale Institute. It's 100 years since Florence Nightingale died next year, and in sort of memory and celebration of her. There are other debates, because I think Nightingale makes everybody start to think about nursing, and that's not necessarily what we mean. But there are clearly other institutes that government has invested in recently, like the Crick and Genomics England, and this would be an institute that would balance those investments to enable that, that sort of research. As Tom's already mentioned, we have a very strong asset base in the Leeds City region for that work, through not just Bourne and Bradford. I think the universities of Leeds, York, Bradford have particular strengths around this that actually brought together would really assist in this work. But it is the case that we have the world's largest longitudinal study of childhood development in the Leeds City region, with huge consented data sets and correlation across different data sets, which is producing groundbreaking insights. I think we're advising the Pakistan government at the moment. So I think we believe we'd be in a good position to actually advise the UK government in terms of its thinking about where it might make investment for health and wellbeing. So that's one of the proposals that we'd like to explore. Last week, the innovation charity Nesta had a workshop on this proposition, which we managed to get the health lead in the Treasury along to, and they are very much looking at this with interest, because they're interested in looking at investment across government departments for health and wellbeing. So it is playing into an interest and an appetite government. It's playing against an asset base we have here, and it's definitely playing against the things you're really concerned about, and our intention to ensure that world-class R&D translates into investment and productivity, which is one of the key issues that we're trying to tackle. So we'll move on to the next slide, if I may. Tom's already referenced the climate emergency and our recognition in the Leeds City region of the need to decarbonise our economy and to move to a kind of viable, sustainable economic structure, and to take the necessary action that entails, accepting that will lead to some disruption in our economic structure and that we need to find a managed way through it. Clearly, on the health side, you recognise the impact that a poor environment has on our communities, whether it's about the air that they breathe, the condition of the houses they live in, the access to green spaces and activity. And we see that playing through, whether it is around, chronic asthma and lung conditions, or obesity levels, or the lack of access to affordable fresh food. It's multiple, the agenda around this. All West Yorkshire authorities, all Leeds City region authorities, actually, I'm looking at Wallace here, have declared climate emergencies, as indeed has the LEP. And we are taking our responsibilities as big anchor institutions with big carbon footprints seriously, to start to look and plan for what that might mean. And clearly it runs across the 5 agendas of energy, food, land use, buildings and transport, and will necessitate diversification of and move away from certain energy sources, creating more access to local food markets, looking differently at land use, looking at passive housing where we possibly can, and modal shift in transport, all of which will bring with it huge health benefits. And I think there's a real opportunity for us to work together across that agenda. It will lead to healthier populations, who in turn are that much more productive. It will also drive our productivity agenda through adoption of circular economy principles for business, because it's very most basic. It's about reduced consumption of resource and diminished production of waste, which is a good in and of itself. So, moving on to the third area in which, and actually I might have put this first because, and I'm sitting next to my leader, who is often heard to say the best way to a long, happy, healthy life is actually to be in work, and good work throughout your life, not scrabbling on the margins of poverty in a low-wage, insecure job, possibly doing shift work. And the Leeds City Region economy has made many and good strides over the last decade, but we all recognise that actually some of our recovery from recession hasn't produced the level of productivity or indeed wage rises that we would wish to see. And the Leeds City Region has already moved in its investments to have a greater level of conditionality around, for example, awarding of grants to businesses to ensure that what we're doing is creating good jobs in which there are prospects for progression and people earn sufficient and they work under good conditions. And again, the local authorities and the businesses of the LEP see a need for us all to be role models in this sense, and to actually model those principles in the way that we operate. And again, I think, and you mentioned the International Day for People with Disabilities, there's a big agenda, we believe, for us about the conditions through which we employ people, that we provide the opportunities for people to be skilled. Our whole health system, I think I can say this, is very challenged at the moment. It has vacancies at every level in every profession of the health and care system. And I know from our own health system, we're projecting the need for an additional, I think it's 15,000 people by 2030. Those people have got to come from somewhere, and we have to provide good routes into their employment in the health and care system and progression pathways. If we're going to thrive as a health and care sector, but also if our populations are going to have good work. So there's a big job for us to do as anchor institutions and think about the health and care workforce. But there's also things to think about in terms of our supply chains, and certainly many councils are working hard on social value procurement, as I'm pretty sure some of the health provider and commissioner organisations are. Bringing all that work together would also drive that greater good work into our economy. And finally, I think the discussion is as important as the input. There's a piece here. It was referred to as one of our grand challenges. Actually, one of the things that the Leeds City region is exceptional in is it is the youngest city region, which is a huge asset for us, which we could also reference about how we enable that young population to be the workforce of the future. But as with everywhere, one of our grand challenges is about ageing, and I know all of us in the health and care system spend much of our time thinking about how we design places as places where people can age well, with the maximum amount of self-determination, independence and choice as they move through later life. How we rethink old age so that people remain productive and contributing for longer, so they are less dependent on state support. They're in better health, so they're less dependent on health services. But there's a huge also entrepreneurial opportunity here to come back to the kind of more conventional form of tech that we might refer to around assistive technologies, and how we design housing and communities so that people are enabled to live independently for us as long as possible. So those are the four areas that strike us immediately. I think actually possibly the fifth one that you referred to that we didn't have on these slides was around the whole health tech and entrepreneurship that goes with that you're working on through MIT REAP, which maybe we also should put into that overlap and get more health input into. But I'll leave it there for discussion, Chair.
Thank you very much. I see any initial questions or comments. Yeah, I'm sorry, I'm struggling to see names sometimes. Yeah, Tony. Yeah.
Hello, I'm Tony Jameson. I'm from Yorkshire and Humber Academic Health Science Network. So really welcome this strategy. I think it's a great piece of work and something that we can really capitalise on in West Yorkshire and Harrogate. One of the things that we've been very impressed with as an academic health science network is just how innovation ready this community is, both in health and in local authorities. And I think that's absolutely fundamental part of growing the the economy, making use of those health tech companies that are out there, because they can develop as much as they want, but if they export all of that to other countries at our expense, then that would be a complete loss. But it's not like that for West Yorkshire and Harrogate. We've got some institutions that have been held up as beacons of excellence in their adoption of innovation, and we've got a willingness to learn from each other on how to spread that. So I really welcome this strategy. That's me. I can't turn myself off.
Okay.
Two on a row. I've cocked up the technology.
So, yeah, thank you for that. And every time I hear this, or a version of this, I sort of see more and more connections, I think, in terms of the item that's coming a little bit later on in terms of our 5-year plan. And just reflecting on that, I'm not sure in our 5-year plan we're really making this connection strongly enough between the opportunities that there are for supporting people into better jobs and the need and demand that there's going to be within health and care services for those people to work. And I just think we can make that connection much more strongly than we are doing at the moment. So maybe we take that forward into the next agenda item, or we think that through a little bit now. I don't know.
Thank you. Wallace, I think you were next.
Yeah, I mean, I too welcome this as a piece of work. I think really that the local industrial strategy has the potential to be quite an important piece of work, really, sitting alongside the NHS 5-year plan. So I think it's a really good piece of work that's been done to identify where the opportunities might be from the local industrial strategy. I do think, though, that for the areas of Craven and Harrogate, we need to recognise that it currently sits within 2 local enterprise partnership areas, and therefore there is a need to do a read across with the list that's also in development for the York and North Yorkshire LEP. Having done a quick read across to that list, there are clearly some areas of similarity and complementarity, and I do think that there is an opportunity to make sure that we also have that LEP working with us and collaborating with us, really, to maximise the opportunities for those 2 places in particular. And then the second point is I really do support the 4 themes, and I think Tom makes a good point, really, about health tech as a potentially a 5th theme. But within the working well theme, I mean, I've got a really strong, passionate view, really, about the need to make really strong linkages between poverty and deprivation and what that means for ill health, and look at ways in which we can have targeted intervention in those particular areas in particular, rather than necessarily adopting a broad brush approach. So in the past, in areas where I've worked, we've actually had targeted intervention in really specific deprived areas, and that's where really this will make a really important contribution and has the potential to make a great deal of difference. So rather than a broad brush approach, I do think really in particularly in deprived areas, as employers as much as anything else, I think there's some great opportunities for us.
Do you want to come back on that point specifically? A couple of things that have been said so far. I've got a few other people, but we've probably had quite a few.
See, I obviously, you'd think I would know how to make this work anyway. So, to your last point, Wallace, we completely agree, Tom, and I think recently the PwC Demos work showed Leeds and Bradford to be the most, well, you'd be the best place in terms of working on inclusive growth, and that's the most improved city on inclusive growth. So we've been working pretty hard on that agenda. One of the things that we are making the case to any government and all governments is for reinvestment in what I call the hyperlocal, and that is the local community infrastructure, which enables people to begin to access economic opportunity. And we, across West Yorkshire and the Leeds City region, we have some very good anchor institutions that exist at a local level in community, and I can see the difference in terms of the prospects for those communities by comparison where we have very little community infrastructure. I know the parts of Bradford District where I am concerned because there's no supermarket, no GP practice, there isn't even a church there. There might be a kind of, the youth centre might have clung on, but we're really seeing the impact that has. And I do think there's an argument for investing at the local, but I think the big employers that are employing everybody from frontline store operative through to manager of a supermarket, those are big institutions in our patch that we can also work with. So I think we have to balance the two, really. But the health economy is a huge opportunity for us to give people who've been economically inactive but have lots of skills an opportunity to enter the workforce, and we should take that opportunity too.
Yes, I've got quite a list, so people think I've missed you. Hopefully I haven't. But so I've got Matt next.
So, Matt Walsh, I'm Chief Officer for Calderdown CCG and Chair of the Shadow System Leadership Executive, who saw this paper yesterday. And I think some of our conversation was coloured by the fact that what was in the paper was in the paper, and there's a load of stuff around this. But a couple of things that came out of our conversation yesterday, which I think we're touching on in the conversation that we're having here, is how do we speak more clearly to those in groups that are disconnected from opportunity at the moment, and how do we make that a priority? So, and I think it's picking up on points that we've exercised. The other thing that's not quite emphasised in the way that we thought it might be in yesterday's conversation was education and the power of education in terms of life chances and the powerful impact that that then has on people's well-being and health. So then the rest of our conversation yesterday about this was, OK, so let's say we support this as we do. What does it actually mean for us? What does it mean for us in our places? And what does it mean for us in our organisations? And where are we going to have that conversation? And what does it look like if organisations are signed up to this? What are we trying to drive as a change in behaviour? So that was the kind of conversation we had yesterday, and I'm curious about that too.
Thank you. Viv?
Thank you, Chair. I, like everybody else, very much welcome this strategy, and I'm fascinated by some aspects of it. And it does talk about health and care, and I suppose a little bit of a challenge, but not a negative one. The care bit, we talk about good work. You won't find, certainly at the beginning level of care, good work. It's some of the lowest paid work around, and I don't see clear pathways, and I think this borders on being a wicked issue, and how this can be taken forward to make that much more credible with a career pathway and people saying, yes, I really want to go into care, rather than it being a fill-in job, if you like.
Thanks, Viv. Julian?
Thanks very much. Julian Hartley, Chief Executive, Leeds Teaching Hospitals. Thanks very much, Tom, Kirsten, for the presentation. Absolutely endorse the approach. Just a couple of things to draw out that made an impact on me. I think, first of all, your point, Tom, about health tech being a key growth area in terms of the economy. And Kirsten, I think the point you made about the Golden Triangle and only 5% spent on the wider determinants of health in terms of research, that put those two things together, and in, I think, finding the distinctive nature of our strategy across this region, we're not going to compete, frankly, with some of the basic science and some of the purely academic work that goes on within the Golden Triangle, but we have got some magnificent assets within the region that we can kind of marshal and use, I think, to claim our place in the sort of overall approach to R&D and indeed health and wellbeing. And at the moment, there is a call for a further round of academic health science centres, which have traditionally gone to the Golden Triangle. I think it's important that we stake our claim on that. I think, secondly, the importance of what we're doing in relation to population health, connecting that to the digital agenda, because there's lots of NHS organisations and indeed across local authorities where there's been significant investment in digital, there's been improvements in electronic patient records, there's been more empowerment and ownership of patients in their own health and care. And as we develop primary care networks, as we develop much greater sense of the NHS's contribution as anchor institutions to local communities, those things together, I think, give us a kind of strong sense of identity and purpose. And certainly one example on my own doorstep of St James's Hospital, working with the priority district of Lincoln Green, which is traditionally an area of, significant deprivation, high unemployment and so on, but having specific careers fairs and working into schools has resulted in dozens of jobs for people in that area. And I think it kind of connect very local, hyper-local place initiatives with a broader piece around research, innovation and growing the economy around some of the more high-tech work. They're not mutually exclusive, we can draw them together, and I think that's what this strategy is about.
Great. Hi, I'm Cathy. I'm the new chair of Bradford District Care. I've got two questions. One's a practical one about the Nightingale opportunity. What do we need to do together to make that happen if we want it to come to this area? And my second one's around strategic. If you're talking about lifetime health in this strategy, and then we're talking about pathways by diagnosis in our health system strategy, how do we get the two things to link together? Which comes back to the points around locality and supporting different communities.
That seems a good point to ask Kirsten and Tom to respond to what's been said.
So there is already quite a bit of work underway in this. So one of the things that happened earlier this year was universities of York, Leeds, Bradford and working together, and also with UCL in London, landed an investment of £6 million from the UK Preventative Research Partnership, which is a blend of health investment bodies. And that was to build an Act Early City Collaboratory to look at investment in the upstream. It's the beginnings of this piece of work. As a result of which, we've been working quite closely with the Wellcome Foundation, which, as you know, is a kind of multi-billion-pound investment fund, and engaging with Jeremy Farrar to kind of build the case outside of government as well as building the case inside government. That's involved a number of us and health practitioners, so the system working together. We've been doing it by stealth, in other words, not for reporting, but we've been doing it by stealth thus far. We've engaged with Treasury senior civil servants who are thinking about the spending review and thinking about how they get greater investment cross-departmentally, which is why we got them to the Nesta workshop on this. Through the Leeds City region, we're beginning to develop the proposal, which we should be sharing across our health system, and then we'll put it into the devolution kind of negotiations. And I think that's where we're at the moment. We're waiting for the outcome. We're sort of waiting for the outcome of the election, aren't we, and to reopen negotiations. But we'll ensure that the whole system is involved and can contribute. So that was the first one. Can I just pick up a couple of other ones? The question, I think it was Matt's question, but how does this land in place? My assumption is we'd be looking to health and wellbeing boards to be landing it in place. Clearly I can't speak for all health and wellbeing boards, but in our system, the chair of our economic partnership is at the table in the Health and Wellbeing Board, and clearly Susan's also chair of the Combined Authority. So we've got a very neat coming together, and we're refocusing on social, economic and environmental determinants of wellbeing. And I think most people are moving to more of that population health management approach. I'll just sweep up a number. If you could sweep up the ones I haven't done, is that all right? on the care, this is tactical from me, Tom. To Councillor Kendrick's point, I think we'd completely agree with you about the issue around care And again, I think a number of us have been making investments in developing the quality of provision through the care system and looking to drive up the quality of provision, which is about getting more to good and outstanding, whether domiciliary care providers or residential care providers. And that in also being about the entry point into the care sector and the kind of training they get. A number of us are working on a 14 to 19-year-old basis around a curriculum for care and entry points into the care system. And I think we could do more of that on a whole system basis. And that kind of touches on your education point, which is that I think we're all doing it slightly differently, because you've got a health academy, haven't you, that you're building. We've got something called Industrial Centres of Excellence, which has got a health and care industrial centre of excellence for 14 to 19-year-olds. I think most of us are doing big careers fairs. Certainly we're about to do one in the new year. So I think maybe, Councillor, Chair, it's about bringing all of that together so we can see what everybody is doing, and that we get the economies of scale that we could possibly get through all of it. The digital point, I think Julie made exactly the right point, is one of the things. We're great at data capture, storage, analytics and cyber security, aren't we? And we have the largest kind of integrated healthcare system, actually, in terms of recording across a number of our places. There's that, and we're also through the LICRA and the partnership, we're working on that at the moment. So we should absolutely maximise that. And now I'm running out of steam, so I think that leaves you with lifetime strategy and health tech. Yeah, which I think you've already made a point on.
Thanks. Yeah, I think I think the lifetime point is a really good one, and it links. I think it does link to the care point. And Tim and I were talking early this week, actually, about last week, about the fact that if we're not careful, the pathway approach acts as a silo, which actually makes people's experience of our system very complicated and stressful and unjoined up. So how do we marry the two? I see a link between the population health work and the more integrated commissioning approaches, and that very person-centred approach that we're trying to take at the left shift, the local neighbourhood level, has been very much linked. But I don't underestimate how hard it is, having had family, friends going through the system recently, the amount of duplication there is and the amount of stress there is in the system for everybody from that, I think, is a big issue. The thing I haven't quite got is whether it's for this strategy to solve that or the other one. And it's probably the other one, but they need to be linked. I do think health tech has an opportunity to do that as well, because the strength we have as well is in personalised medicine, in Leeds in particular, and there is that Mike Messenger is working with Born in Bradford. It's David, isn't it, from Born in Bradford, who is it? John Wright from Born in Bradford and Mike are working together, and this is about highly personalised approaches to treatments that can be much easier on people and more targeted, and therefore better for them and with better outcomes as well. And linking that into the health tech stuff around how people live their lives and using tech in a positive way in that sense, and a lot of the apps that have been developed in the tech sector in the city region, there's big opportunities there, I think as well. And I think Kirsten covered it all. The only other points I would make, Julian mentioned the Lincoln Green work, and I would just say there's an Anchor Institutions programme that we developed with Joseph Rowntree Foundation at the city region level, that all the health institutions in Leeds are now signed up to, that we're rolling out. It's a cookie cutter approach that you could easily apply to others, and I think that answers the question about what does it mean for us, because I think that Anchor approach can help you do some of that hyper-local stuff that Julian talked about, which is fantastic, actually, getting people into work. And then final point was just about, we don't underestimate how much, what a prize this is, because usually when we're talking about the economy and these sort of issues, we can never beat London, because London's just this amazing global city and global, you know, almost, you know, it's like the global capital of the world in some senses, economically, rivaling New York. But London cannot do the collaboration that we can do because of the way the health system works there. And the other thing about Oxford, Cambridge, etc., is that they can do the research side and the tech side, but they don't have the richness and diversity of population and geography and socio-economic groups that we have. So that's why, when they looked at it in Boston, they said, actually, the fact you've got the NHS based here as well, this is really stand out. So this is a huge opportunity, I would say.
Thanks very much, Tom. So, Pippa, apologies I missed you earlier.
Thank you. Yeah, just so Pip from Harnessing the Power of Communities, Pip Goff from Leeds. From a third sector and communities point of view, incredibly welcome to see that we're talking about this whole strategy being around kind of people and assets and value, not just about money. So incredibly welcome from that third sector perspective. I guess I would just, it kind of follows on from your last point, Tom, and a number of points around the asset that we have in this region. And I think this is very, very strongly supported by the third sector, community, voluntary, faith organisations that we have. Not just because they really are there in communities, as Kirsten said, they're the organisations that are kind of really addressing people around poverty and work and diversity and all of those issues in place. Something that was really recognised locality, a really important national organisation held their conference in our region a couple of weeks ago and really celebrated some of the fantastic anchor community organisations that we have. We haven't universally got that equally funded, and the third sector is one of the most precariously funded bits of the system. A really, really important part of the workforce opportunity and the pipeline into more professional employment in health and social care. Very often people will begin volunteering and having experiences and placements in third sector organisations. But it really is a precarious bit of the system. So we also absolutely need to see that as one of the significant assets for this strategy and think about how we really kind of make sure we're strengthening that focus, because, yeah, I think it's exactly one of the strengths that we have for this region, but we mustn't take that for granted.
Thank you. Rob, you wanted to come
in. Thank you. Thanks for the strategy and for the conversation. It's been really good, and I've really enjoyed the focus on people, inequalities, assets, as Pip just said. One of the groups that faces the most health inequalities and the lowest life expectancy in West Yorkshire and Harrogate and in the rest of the country is people with a learning disability. And one of the groups that is least likely to work are adults with a learning disability. Only 7% of people with a learning disability are in work, despite the fact the majority of people with a learning disability want to work. There's some good work going on in this place, in West Yorkshire and Harrogate, to look at job crafting. So what we normally do is, if you want to employ someone with a learning disability, we carve some of the job up so they can do it. And what this approach says instead is we'll craft a job which works to your skills. Because you may be somebody with Down syndrome who's got good visual memory, you may be somebody on the autistic spectrum who has other skills and attributes to bring. So what will the strategy do for people with a learning disability?
I think it's a great question, and I think we probably need to link it to the anchor institution point and see what we're doing already, because I think there is some good practice, and I certainly know ourselves we have some great history of working with people with learning disabilities in our park service, for example, and that has, you know, served us extremely well and served people with learning disabilities really well as well. But I would like us to utilise the tech sector for questions like that. We've come back from Boston, and one of the things they do in Boston is they set challenges for the societal challenges for the tech sector. So they'll put a prize up or a competition up for the tech sector around an issue or a challenge or that could be in society or in business. And I think it's a great example of something where we could challenge our tech community, who I think would be really interested in getting involved. And actually, in speaking to a lot of the tech companies, they have this is a really good opportunity, particularly for example, people with autism who actually are thriving in some tech companies and are bringing something quite different to their workforce in a way that's fulfilling for those people as well. So I think it's a really interesting question. We don't have the answer yet, but I think that's the sort of thing that we could take back.
Rob, you want to make some comments as well?
Yeah, so as well as asking a tough question, I just want some offers, I think, to make from an ICS perspective. So I think we've had exactly the right conversation, and there's sort of 5 points I'd make, really. So the first is to pick up Councillor Kendrick's point about care and good work for people in care. And I think if we don't answer this question, we're going to be in trouble. Because we know that people with care needs have health needs, and they're two systems butt up against each other. And that the turnover in the care system is significantly higher than in the NHS. My suggestion there is the workforce group that we've got looking at the integrated workforce strategy comes up with a set of proposals that are going to address this issue. We're already looking at it, but let's make sure it's covered in the workforce plan that we're pulling together. The second is this point about, I think, anchor institutions as employers and economies of scale by working together on the Skills Academy and the Excellence Academy and so on. And the fact that integrated care systems, the NHS plan is pushing for, I think, partly at our bidding, integrated care systems to be the ones who are looking at how you work with schools and local partners to ensure that people far from employment or in education get into work. So we should probably do some work together on that one. The third, I think, on the health tech piece, we are one of the first places in the country to sign a memorandum of understanding with the health tech industry through the Association of British Healthcare Industries, and I think we can make a lot of that in terms of that end of the spectrum of being ambitious. Fourth, I really think the question about how do we get behind the Institute was a really great question. When we all got behind things like the local health and care record exemplar, we were successful. When we all got behind the recent bids for a cancer centre for research, we were successful. So I think we should all get behind the Institute, because I think we've got more chance of being successful, because this partnership, our partnership, has got credibility. So we should use it. And I think the final point I would make is a plea really for people to probably think slightly differently about these two strategies. So I think Kirsten said 85% of things that affect your health have got nothing to do with the NHS. People argue about this. Sometimes it's 20, sometimes it's 15% of things to do with healthcare. But around 80 to 85% of things got nothing to do with healthcare. You know, it's having somewhere to live, someone to love, something to do. And that means that this strategy, this industrial strategy, and the long-term plan are the same thing. If you start from someone's life, they're the same thing. And if we think ourselves into that space, I think what we're saying is having good work, having a good environment, having good housing will help drive good health. And then we can have a good healthcare system to respond when people are unwell. So that's the first thing. And beyond that, as Tom says, we are uniquely placed globally to take advantage economically of where we sit on that innovation and health tech space, so we should. So my plea to you, and you might disagree, is that we should all think that this is the same. If you start from our population, our people, it's the same stuff.
Thank you. I'm sure our last point probably reflects the approach many of us have taken to wellbeing strategies in place, are very closely seeing them as interconnected. So thank you to everybody who's contributed to that debate, and to Tom and Kirsten for presenting it. clearly some of these comments will be fed back into the work on the industrial strategy, but I think the paper does also pose a question at the end about how we take that forward. We discussed some of that here, but probably there's a little bit more thinking to be done probably through the executive group. Is that the way? Yeah. Okay. So thank you very much. That's if I can move us on then to item 24, which is communications and engagement. This is Karen and Helen. Can I hand over to Karen? Is it yourself first?
Hello, can you hear me? Yeah. Thank you, Chair. Good afternoon, everybody. I'm Karen Coleman, West Yorkshire and Harrogate Partnership. Very proud to work for the partnership, and that means I'm very proud to work for each and every one of you and our communities, of course. So I'm just going to give a little overview on communications engagement. First thing I'd like to point out, though, actually, is that I hope I do the Comms and Engagement Network proud across West Yorkshire and Harrogate, because absolutely it is their work just as equally as it is everybody's work in this room. I'm just going to give a tiny bit of a sound snap of some of the work that we've done, and then I'll hand over to Helen Hunter, who we work very closely with from Health Watch, and then I'll just tell you a little bit on the final slide about what next from us. Oh, I forgot I had my clicker then. I truly believe this, as a mum, as a grandma. I know I don't look old enough, but as a grandma, I truly believe our partnership belongs to us all. I think the better that we work together with communities, staff, politicians involved across every party, local and wider systems, the better we're going to design services and meet the needs of all of us, and the more chance we've got of creating something that will be useful to us and something that's easy to access. I think you see some great examples of how we've been doing that when you look at the work that we've been doing around things like work with health and care champions around learning disabilities. We shouldn't be able to really speak on their behalf. We should be listening and actively acting on what they're saying and looking at how we can make things in life much more better for them and their carers. We guide by a few comms and engagement principles, and these are written down in our strategy, which we update every year. Accessible and inclusive. I think that's a given. I think those that we serve across West Yorkshire and Harrogate, they shouldn't have second standard information. I'd feel quite insulted, actually, if I was a carer of somebody with a learning disability and I got given an A3 piece of paper that was photocopied when somebody else next to me was given a piece of quality information. I absolutely live by them standards, and I know my colleagues do too. I think data, we don't do anything unless we've got good insight, and I'll come on to that a little bit later on. But you can see the evidence of the work that we've done. We start from clinical evidence in the work that we're starting to pull together around a reduction in suicide, to potentially do a campaign next year if there's an appetite from the board and further afield for that. And also our neighbours, if you're looking at that, you'd never guess that was a medical model. That is absolutely grounded in A&E targets. And so we look at all the insight before we've got anything to take it forward. Clear and concise. We try our absolutely best to make information that's clear and concise. That's not easy working with you guys sometimes. You come out with some really big words, and especially because I used to work for a council for a lot of years in the charity sector before that, I spent my first 3 months asking, well, what does that mean? You know, and then reminding myself that actually I am quite clever. I just don't know what that means. I think we're accountable. I think we're accountable not only to ourselves as individuals to do the right thing when we communicate and engage, but we're accountable to every person who pays a pound of that tax money. And more importantly, for those people who can't speak for themselves, we have to make sure that they've got a strong voice to bring that through. I think we have to be flexible. We don't always get things right. And I think sometimes we have to be prepared and be brave and bold enough to say, actually, that's a really rubbish piece of information. We need to improve on that, and we need to do that in a way, in a format that we can be proud of. And it's not unusual for me or my colleague to say, or to challenge me, actually, to say, you know, it needs to get better. And it's not unusual for me to say, I'll do without that, but actually I won't compromise on that. And I think it's about raising them standards and bringing them hard and up to the hard line, really. Open and honest. I think you shouldn't work in communications and engagement if you're not open and honest. I think that is one trait that goes hand in hand with that personality of a professional communicator or a professional engagement manager or officer, is that open and honesty should come first. I also think that whenever we do information, we have to be targeted. And what I try to demonstrate that absolutely all our information should be targeted, and it should start local. It absolutely should start local. I think there's opportunities for us to work at West Yorkshire and Harrogate and our communications, but I don't really care, if I'm totally honest, no disrespect to what's going on in another area of West Yorkshire. I care, or Harrogate, I care what's going on in Almonbury, and why would anybody be any different? So what we try to do is we try to tailor our information, produce it for the target group that we're trying to reach, and above all, make it relevant to that person and purposeful to their lives. And then we're two ways. We've got lots of mechanisms in place to try and make sure that we're catching everything that people are telling us and being timely in our response. And I'll try to demonstrate how we're trying to do that. Oops, there's it, go back again. I think we all have a role, each and every one of us, whether you work for the partnership or not. We all have a role to actually be engaging and communicating and making sure that we're raising the profile of our communities. I'm a very proud citizen of where I live. If I can't shout out for my town, who can? And I think equally as a communication and engagement officer, I think you've got a role to PR too, and we have to make sure that we're raising the bar. In all our information, we try to be co-produced. We try to co-produce every single thing we do. If you look at our website, that's been through feasibility testing. It probably needs another go-through right now, if I'm honest, but that's been through feasibility testing of people of all different communication needs, and they've tested that information to make sure that it's accessible and to make sure that they understand what we're saying on there. Our comms and engagement plan that we produce every year, which sets out the ambitions, that's easy read, and we do that in other formats as well. When you look at our guidance framework for how we communicate and engage with staff, that is only guidance. Organisations don't have to do that, but we worked with the unions and we worked with the HR departments. Our involvement plan have our principles that guide us to make sure that we engage and consult in a fair and honest way. They've been co-produced with engagement managers, colleagues from Health Watch and some of our VCS colleagues also. So I guess what I'm trying to say really is that we're not an island as an ICS in terms of comms and engagement. We can't do everything. We don't know everything. We're certainly not experts, but we do need to be honest and open and ask for that help whenever we do need it. Telling our story. I should have given you all a little bit of a warning at the beginning. You might see a little picture of yourself. I think you're all very handsome myself, but then I would say that, of course. So when we look at this is an amazing piece of work that our Black, Asian, minority ethnic colleagues did across West Yorkshire and Harrogate at some of the middle management upward level, but what was really inspiring was that it was led from the top and it was very heartfelt. So I'm a big believer that we try and do our comms based on the audience, and I always think about the value of that video story. What is the purpose of it and what are we trying to achieve? And it's the ability, I believe, to emotionally connect with your audience that makes the biggest difference. And I think some of the positive successes we've had as a comms and engagement network have absolutely been around our uniqueness to be able to get to everybody, to reach people, and to put our hands up to say, we haven't done that very well, we're going back out again, and we're not going to stop till we've talked to people. So communications and engagement, a little bit of the backdrop story really. Over 100 comms and engagement colleagues make up our network from all our 26 big organisations, including our 8 councils and health watches, as well as some big charities, for example, Cancer Macmillan, and also some others like Touchstone and Mencap in that. And that network meets every 3 months. And there's about, I'd say, to be fair, we move it around the patch because we don't want everybody to be cursed, and we don't want to, rocket up them carbon emissions. So we do move it around the patch a little bit, and what we tend to get is between 35 and 40 comms and engagement professionals coming every 3 months to share learning good practice, do some development workshops, and most importantly, actually, to hear what each other's doing in their areas. I think next week, Matt Walsh, we're coming to you. Prepare yourself. We'll be coming out, and we're going to be having Andy's Man Club along there, and we're also going to be talking to Calder Girl Council, comms colleagues, about some of the wonderful work they're doing over there. I think also as well what we try to make sure that we do is we communicate at every level. We try to do lots on things like vlogs, videos, all the things that you'd expect to see in large organisations or some smaller organisations. But I think the key thing that we try to do is we're communicating all the time. And I think what I'm really, really proud of is the way that we do that at speed. And we take every single conversation we receive, whether that's a public question in this environment, whether that's a comment on Twitter, whether it's something private on a Facebook message, whatever that might be, if it's from the media, the radio, whatever. I've been brought up in a council, and, you know, I'm very keen to make sure that we respond within 48 hours, and we always try to do that wherever possible. And then political, of course, you know, these people have been voted in, councillors in this room, you know, democratic process. You've got every right to ask your questions, keep asking us, maybe mine, but if you'd like to move on, but keep asking us all these questions. You've got every right to ask us whatever you want to know about. You've been voted in by local people, your local ward constituents, and we take that very serious. So here's some examples of some of the accessibility stuff that we've been doing. We've been working with our partners across West Yorkshire and Harrogate, and there's about 16, 17 organisations that come together to develop a health and care disability champions for people with learning disabilities, and that's seen some really good work going on at the moment around cancer and around some of the things like improving planned care into hospitals and also maternity care. There's some really hard, I find it very stark, actually, some of the stories you hear from people of all different abilities, really, and we need to look at how we can address that. And that work's really coming together nicely, and we're recruiting health and care champions at the moment. We also do information, as you would expect, or as what I would expect, is information in alternative formats, subtitled, easy reading audio, and we test our information. So none of our easy read or our audio or our BSL information is done from some corporate company, sat down wherever they may be. That is all locally led. We move it around to make sure that we're being fair and giving everybody the opportunity to work alongside us. These tend to be small charities, but what I absolutely love about all of this is that they get people together in that room with that lived experience, and they tell us how they want their information. They tell us what picture's important to them. We don't tell them. And then engagement. People don't define themselves as part of the area of West Yorkshire and Harrogate. For example, they say they're from Halifax. I would say I was from Almondbury. And what we have to do, and what's really important, and what makes our comms and engagement network possible, is that we have access to all their comms channels, and they work with us to make sure that it's not bumping in the way of local information, it's not getting in the way of some key corporate messages that need to be going out. And what we do is we try to work with them, really. I must be a real pain, if I'm honest, but what I try to do is I try to work with them and to develop information that we can all use and it can reach everybody we need it to. And then every year we map out our consultation engagement timelines, so we make the most of insight intelligence. We never start from scratch. We look at everything we know already. The last thing we want to do is duplicate time, effort and cost. And most importantly is people's time. If we've already asked them a question, why go out and ask them again? And we use that insight to inform the work that we do. And that's actually seen as best practice nationally. And then the other important thing that we always try to do is that we always try to tell people, you said that, so we've done this. And then we'll put that out and we'll make sure that that's available for people to be able to access. And we bring lots of lay member expertise onto all our programmes of work. For example, the Cancer Patient Panel, the Maternity Voices Partnerships. Is it moving? Yeah. And so all of this, really, to wrap it up, really, is that we make the best use of Health Watch community assets and comms and engagement expertise. They often know far better than what we do. We use various approaches to reach people. There's a regular flow of information coming out from our partnership via networks, print, online or social media. And in addition to more formal communication, we like to think and believe that our visions and plans are resonating locally, but people don't necessarily know where they come from, but their messages are absolutely aligned to everything that we want to do, which, for example, is improve people's lives. We focus on joined-up ways of working through shared practice and work together only where it makes sense to do so. And this is one particular thing that I was really proud that I shared with the Comms and Engagement Network. It was felt that our ICS could follow, that other ICSs could follow the same approach to public information provision and the regular flow of communication updates as West Yorkshire and Harrogate Partnership does. But they can only do that if they build on the good working relationships that we have at our ICS. And I felt very embarrassed but very proud when I was told that West Yorkshire and Harrogate was the best example of comms and engagement. And then I think the last one from me really is just some examples again really of how we've tried to make sure that we're being open and honest, is that people can get involved at any level of the partnership. People can text me if they're hard of hearing. They can absolutely get in touch with us via email, the website, social media, the lay members, the youth forums that we connect in with. Our door is always open. The Partnership Board, of course, it meets every 3 months, and we also have our joint committee, which is also web streamed. So I hope that helps give you a little bit of a flavour. I just hand over to Helen. Oh, you pick that one up. Don't pick that. Shall I do it? Sorry, just the last one from me. Examples of what we can really do together. If you look at our neighbours, I think our organisations support us. As of yesterday, up to about 380 organisations. That's amazing, isn't it? That's amazing. I think that demonstrates the value of the comms and engagement networks, and most importantly, our local communities. And there was some of them. These need updating. Actually, that was around June, July that slide was done. And sorry, just the takeaway message is really is that people aren't particularly interested in the ICS. I think we have to be honest about that. But what we do have to be honest about is where we can work together and where it does make sense and where we can use resources better to make sure that we're getting our messages through. And then I think also is that not overemphasising the badge of the ICS, but absolutely highlighting where we can share that learning. And that is definitely me, apart from having the best great comms and network in the country.
It's always the hardest part is dealing with the mics.
It is.
I'm Helen Hunter. I'm the Chief Exec at Healthwatch Kirklees and Healthwatch Calderdale, but when I attend this meeting, I attend as the representative from Healthwatch across West Yorkshire. For those of you who've had the dubious pleasure of listening to me talk about engagement before, you'll know that I'm incredibly passionate about the opportunities that talking to the general public bring. I think that we design better services, we create better opportunities, and we get better outcomes if we understand what the public think of the things that we are trying to achieve. And I think that that needs to be part of our ongoing conversation with the public. So I wanted to start by talking about the opportunities that I think come out of engaging with the general public. The first point that I've put up there is about things that make people want to talk to us. So if you want to know what people think, our engagement needs to be relevant to the individual. And I think that we can achieve that in two ways. Either we make engagement very broad, and that means that people can adapt and think about the bit of it that's most relevant to them, or we make our engagement very targeted and ask the right people specific questions about things that would be of interest to them. I'm sure we'd all agree that in this room that if you are sharing your view, it needs to feel like it's going to have an impact. It needs to feel like it's worthwhile doing that, because actually people lose interest very quickly if they share stuff and they don't feel like anything comes back as a result of that. And it needs to feel like it's purposeful. And often the best opportunity for the public's voice to have an influence is if they are involved from the outset rather than toward the end of a process. I want the public to be seen as a trusted advisory group that we go to when we've got ideas, that we go to because we want to shape and mould the way in which we work, rather than feeling like we need to have something that's really thoroughly planned and thought through before we consider asking for that perspective. I've put on the slide that engaging isn't about limits. Often we have to think about what it is that we're actually going to engage about and make sure that those questions are sensible and relevant. But we need to be open enough that we can hear the feedback that comes in around the outside of that and adapt what we are doing in response to what people tell us. I think sometimes that can be quite uncomfortable. And I think it's really important that we are open to hearing the variety of different views that people might share with us, because it gives us pause for thought. It makes us reflect on our accountability to them and whether or not we are making the right decisions and doing things in the right way. I'm aware that later on in the agenda we're going to talk about the terms of reference, and there's a part of that which is about kind of communication and engagement. And for me, I'm not sure how well we've captured that opportunity and that challenge that the public can present to us in the way that we've articulated comms and engagement there. I want to tell you a little bit about how Healthwatch work with the partnership. I'm the person that comes to this meeting and I come to the System Leadership Executive, but actually I can only do that because I work with a fantastic team of other chief executives, all of whom are very angry about the pictures. I work with this wonderful group of people to try to make sure that we are, and we are all very clear about what it is that we're trying to do to support the partnership. And I think the two key things, although I think there's one that I'll add on, the two key things that we're trying to do is amplify the voice of the public and the information that we hold. Sometimes that happens, sometimes we hold some information because we've been asked to gather that information by the partnership or by individual organisations within it. So we're able to contribute that. Sometimes we need to take a more bottom-up approach, because Healthwatch is hearing about something that the partnership isn't perhaps necessarily cited on or aware of, and we want to make sure that they get to hear about that. So at the moment we're linking in with the mental health, learning disability and autism work stream, because we're hearing as a network of Healthwatch a lot of information about autism. We want to make sure that that's captured on that footprint. The other important part of what Healthwatch does is reflect back how important it is that we actually engage with the public. We can't possibly, we're probably your smallest partner, one of your smallest partners in the partnership, so we can't possibly provide everything. Sometimes we need to be an advocate, and it's great to be able to work with Karen's team and with the wider comms and engagement network, the lay people who are kind of within the work streams, to champion hearing the public's voice, and that's a really important part. But I think the thing that I've perhaps missed off there, which is a thing that Healthwatch I think has a really critical role in, is being a critical friend to the partnership and being able to say, we want to help you, we want to support you to get engaging with the public right. And the last slide that I've put up here is about the most recent piece of engagement work that we've done with the partnership around the NHS long-term plan. So the engagement work itself took place in March and April of this year, where we engaged with 1,800 people across West Yorkshire and Harrogate to understand something about their understanding of the long-term plan. We focused particularly on personalisation and digitisation because we acknowledged that there were gaps in some of the intelligence that we already have. I think what I'm really aware of is that 1,800 people is a great return. It gave us some really juicy information, but actually with over 2 million people living in that footprint, it's a tiny, tiny drop in the ocean of what people think, because I don't think there's a single person who wouldn't have something to say to us about the NHS or about social care. And we need to be mindful that this piece of work, which gave us some great insight, can be a springboard for talking to people around other things going forward. What I would say, as a group of Healthwatch, we've refined some of the findings down to these I statements, as I call them. I don't think there's anything that's up there that's particularly revolutionary or that would be unexpected. I think what's difficult is that these non-revolutionary things are actually surprisingly hard to achieve. And I think it's really important that when we are taking decisions and designing things going forward, that we kind of keep these in mind, and whether or not we're going to be meeting the public's expectations with what we do.
Thank you, Helen. And just to finish off, really, because I think Helen makes a really important point. Healthwatch did an amazing piece of work across West Yorkshire and Harrogate, reached 1,800 people, 15 focus groups with lots of people from different protected groups, for example, carers, those with dementia, young carers, young people. But actually what we actually do with that insight and how we knew there was a gap in digitalisation and personalisation is we mapped that across all the work that our colleagues had done in our local areas around engagement, and that's how we were able to identify that gap. So it was a great piece of work and we were all very proud of it. So what next really? We'll be mapping out our engagement and consultation work this year, ready to look at for next year. So we've got the insight one once approved, following obviously the new government coming into post, is that we will be then looking at what engagement work we need to do to deliver on our ambitions of our 5-year plan. We'll also be working with our health and wellbeing boards and joint overview scrutiny committees, and also our partners in the local areas, of course, will be linking locally, as well as the engagement colleagues, to see if there is any other gaps or what new intelligence is coming round, to make sure that that's informing the further development of our plan. And we'll also be developing a comms and engagement plan to make sure that we realise the ambitions and we communicate them well over the next few years as we implement them. And then we'll continue to work with all our partners, because they know far often than us what's better for them. Thank you, everyone.
I'll get this right in a minute. So thank you very much for that very, very thorough presentation. I think we agreed last time we wanted to get a wider understanding of how the communication and engagement work was taking place. Are there any quick observations on comments on that before we break for tea? Yeah, Pat.
Thanks very much. It's Pat Keane from Wakefield. I was struck by the challenge, I think, that Rob gave us earlier on about the earlier strategy and health and well-being, and the 85%, 15%, whatever it is. It struck me, my reflection was about engagement and communication. And do we need a different narrative? Do we need to be thinking about how we engage and communicate with a golden thread around the 4 pillars that we talked about in the earlier conversation? That it's about people's life, it's about employment, it's about... We all know, I think most people in the health sector know that, 15% is all, of health care makes a difference, the rest is not. Do we talk enough about that? Do we engage? Do we communicate? The personalisation is a term, that I think people would recognise that. But my reflection is: do we need to think about the wider narrative around communication and engagement in the context of what we've heard today?
Yeah, I'll take 1 or 2 comments and ask you to come back at the end, if that's okay. Cathy.
Sorry. You can be Helen. I can be Cathy if you want. I don't mind. I answer to anything. So mine was just an observation and a thank you, really, to Karen and Helen. And I think I'm just continually sort of impressed by the quality of the communications and engagement that comes out of this partnership, how current it is, how up-to-date it is, how responsive it is. And I'm just, it's just a really big thank you, really, and hope we all recognise the amount of work that they do on behalf of us all.
Thank you. Okay. Helen or Karen, you want to come back on Pat's point particularly?
I think that's a really good point, and I think when you consider we started drafting, all of us together, the 5-year plan, didn't we, earlier on this spring, and you can just almost see how we've moved and it's shifted to that position, exactly what Kirsten and Tom were speaking about, and the points that Rob helpfully highlighted and that you come back with, Pat. And I think if we get to the position, once after the elections we've got a date that we're happy, everybody's happy to launch that, then the whole comms and engagement approach needs to shift. And it will absolutely shift. And we'll do a strategy and we'll co-produce that strategy with my comms and engagement colleagues. And we'll get something that absolutely reflects the true direction of where we feel like we're now going.
So again, I think when we look at the long-term plan draft next, if you've got the electronic version, you can click on all of the different case studies and examples which are drawn from all of Karen and the team's work. And I think it's just built up over a long time. And it's very easy for me when I get asked in other conversations nationally and elsewhere, what is the partnership delivering? I can just point to a load of material, which is incredibly important for building our credibility. I think the question I've got for the Partnership Board is whether we want to use the I statements that Helen pulled out as a test against the plan. Because it seems to me it would be a really good test to see that, because you talked about it being difficult to move the position on some of those, shouldn't we be asking ourselves whether the strategy delivers against those things so that people from BME backgrounds, for example, find it easy to access care? It would seem to me a really good set of tests we should maybe just look at when we've got to a reasonable place with a plan to make sure it's delivering what people want.
Okay, I'm seeing some nods of support for that as you were saying that. So I think that's something we would like to take forward. Yeah, but Susan, yeah.
I just think I wanted to lose a point the gentleman made over there about the fact that we could use, if we have any resource, to be able to bring people along with us about what health is. And it's not just about hospitals, it's about that wider picture. So I think that's a massive piece of work, actually. And I think probably we all need to share in that, actually, in terms of our comms. But I wouldn't want to lose sight of that point. I think it's well made.
No, I think it's a very fair comment. If I was allowed to say anything about the general election, I'd say the general election campaign is a good example of everybody talking about hospitals and not health. But I can't say that, so I won't. Okay. Okay. So thank you very much again for that. We'll note the recommendations and take forward that point about the I statements. We're slightly ahead of time, I'm pleased to say, so we're timed to have a short break now. So I think tea and coffee is available back where it was before, and I'll suggest we aim to reconvene at 3:45. Thank you. So it's me.
Speak.
Okay. I think we've got most people back in, so we'll reconvene. Thank you, everybody. So I do know that the breaks are the most important times in terms of work being done, actually, of course. But okay, so next item is the next stage in developing the 5-year strategy. Rob, can I hand over to you?
Thanks, Tim. People have got copies of the draft 5-year strategy, the executive summary and the easy read version. Just to remind people that one of the big pieces of feedback from the last conversation we had was this doesn't feel like our plan enough, which felt like a really good bit of feedback in a way, because people are ambitious and anxious for this to feel like our plan. It's not just a response to a requirement from the National Health Service to have a 5-year plan. It's more than that. The long-term plan for the NHS is just a chapter within a broader piece which covers public health, health inequalities and the wider determinants, as we've just discussed. So this is our plan. Just to say, the engagement we've had on this process through health and wellbeing boards, organisations and partners and stakeholders has been really fantastic. And what I would hope is that what you can see in the updated draft, some changes and improvements to the plan on the basis of what you have told us and what people have said. Within all of this, we've been trying to make sure that the plan makes sense. There are some specific asks of us in terms of the money that we spend, the things that we do in terms of activity and the staff that we employ, and making sure that that all adds up so that we can afford to employ all the staff we say we're going to have, that we can deliver all the activity that we say we're going to deliver, and that we can manage the money together in the right way. And just as Karen described in terms of work communications, we're seen as pretty good at this. I think some of the work we've done across the system in thinking about how we manage the money together has been excellent. So thanks to everyone for that. I think the documents are good. I think they're only as good as the action that follows. And I hope what you can see in them is there's a really strong sense from the beginning of look at what we've achieved so far and lots of examples of what we can do. But what we need to do is to make sure that we build on this into an action plan. And the good thing is that that action plan and the work so far is led by programmes which are led by chief execs in this room. So this really is a collaborative effort. It's distributed leadership. You know, it's not me, it's everybody. Everyone in this room is doing something on some programme, and everybody is doing something in some place, or everybody's doing something in some sector. And all of that adds up to the delivery that we need, really. I think that our collective effort will see us through, and that's why we're a partnership. There are still a couple of things that I think need sharpening up. If you look at the 10 big things we want to be known for, there's a couple of those that feel that they could definitely be sharpened up. We just had a conversation about the industrial strategy, and there are some elements of that I think we could lift out to really put some precision into what we want that to contribute to people's health. I think the statements around BAME leadership are really well intended. Maybe we could sharpen those up, and the climate change piece. Again, there's some strong statements there. Is there anything we want to do to sharpen those up? As has been mentioned, we are in the pre-election period. We can't finalise the plan until after the pre-election period, and there's some further engagement to do. All of the main political parties have made some pretty strong statements about, somebody mentioned earlier, hospitals, but also nurses and GPs and staff, and a lot of things which will impact upon our strategy, I think. So I'm going to hand over to Ian, who's going to take us through some of the key changes and updates since we last had a conversation and based on the work so far.
Thanks, Rob. Yes, and just to follow on from that, I'll just talk a little bit about the feedback that we've received, the main themes of that feedback, how we've responded to those pieces of feedback in the documents, and just take you through the 3 documents that you've got in front of you today. So in terms of feedback, and just to echo Rob's point, the amount of engagement and interest in people who want to help and pick up a pen and develop this with us has been really, really good, and it's felt genuinely, kind of really authentic in terms of people wanting to get involved in this. So that's been great. The themes of the feedback that we heard, I guess, the first thing that we heard loud and clear was that there's a huge ambition within this partnership around health inequalities. So we've been challenged by pretty much every health and wellbeing board to really up our game on health inequalities in this plan. I think it was Bradford Health and Wellbeing Board who said we want this plan to be the best in the country in terms of its ambitions around health inequalities. And so, as Rob mentioned, through the Improving Population Health Board, led by Robin Tuddenham and James Thomas from Bradford, I think we've got a really a much stronger narrative and a much stronger focus on health inequalities in that. But in addition to that, throughout the document, there's a really strong health inequalities theme to it, I think, through all of the ambitions. So we've done some good work on that, I think, and I think that's moving in the right place. The feedback we've had from NHSEI and PHE on the health inequalities element has been really positive, and they're keen to use our approach as a national example, so that's good too. So that was the first theme. The second theme was around the conversation we had earlier, really, the importance of social determinants of health and well-being, and that needs to sort of sit centre stage within our strategy. Again, we've worked to sharpen that. I think, to Helen's point about whether it's strong enough, I think what we've done is we've described an opportunity. We probably haven't got into the specific things that we might do together, and the 4 or 5 themes that we've agreed today might give us that framework to allow us to do that. So I think with a bit more focus there, we can probably get close on that. Thirdly, social care. The first draft really underplayed that symbiotic relationship between health services and social care, the pressures on social care, and again, working with Director of Adult Social Care colleagues from across the partnership, we've included a specific section on social care now, which I think describes some of those challenges and ambitions. We can build in the stuff around social care workforce that we've heard today, which I think is really important. Fourthly, and it's this point that Rob touched on around distinctiveness and ownership, and I think people are really proud to live here and work here, and they want a strategy that reflects that distinctiveness and that sense of us. That's not the world's easiest thing to do in a document like this, but the way that we've approached it is that we've got a short summary document which describes each of the 6 places, which is where I think a lot of the richness comes from. We've set out the 10 ambitions that Rob mentioned, and that summary document is really our attempt to draw out that sort of distinctiveness, and this is what we're about. End of life. So we got quite a lot of feedback that we hadn't really mentioned end of life, particularly from Kirklees Health and Wellbeing Board. So we've addressed that, and Karen Jackson's been leading a group across West Yorkshire and Harrogate to help us with that. And then finally, the first document, we received quite a few comments about how dense it was and how hard it was to navigate. It felt a bit of a hard read and a bit boring at times, and I think what we've tried to do, and through the design version, is have a document that flows a bit better. The way that we'll present it on the website will be chapterised, so people can dip in and out of the specific chapters. So hopefully it'll have a bit more user-friendliness to it than the previous version. Since we published the document on Tuesday, we've received a further set of comments from the West Yorkshire and Harrogate Joint Scrutiny Committee. That builds on the comments that they provided to us in September, following the Partnership Board conversation in September. What we'll do is we'll look to address those comments appropriately alongside the comments that we received today, so we'll feed that into the mix as well. So you've got 3 documents in front of you. The green one is the next version of the big document that we talked about in September, and hopefully you can see how that's moved. The sort of purpley lilac one is the standalone summary document that we're calling it, which puts those 10 ambitions front and centre, and which talks about the uniqueness of the places that make up the partnership. And the third document is the easy-read version that we worked on with our colleagues BTM, who you met at the September Partnership Board. They came along and presented. In addition to that, there's a little explainer animation that's embedded within the paper, and once we've got a settled draft, we will work to develop a BSL version, British Sign Language version, and an audio version, so that we're being as accessible as possible. So interested in comments today. We'll then need to reflect on what happens in the general election next week and develop a process to finalise that. We're keen to do that as soon as practically possible. But thanks for all the input so far and keen to get further comments.
Thank you. So can I invite questions and comments? Angela, yeah.
I just wanted to say I thought it's a really good. I think it's very well presented. I think it's much more accessible than previously. The two summaries I think are really make the points in a very clear way. So I think congratulations. I'm sure Karen's had quite a lot to do with it. So congratulations, and I think that it's worked very well. These strategies are always work in progress. They're always going to be dynamic and evolving. So it's never going to be absolutely spot on for everything. But I would have thought it was very good representing what we're all about. So I would say congratulations. I just got a comment which is really, I think, about my ignorance, and it's not about the strategy. I'm going to lose my place now. We've got the organisations who are represented in the partnership board, and we've got very helpful at the bottom of on the summary document, page 5, our health and care landscape, which has got a great box at the bottom with all sorts of elements of mainly the health and social care system. What I'd been looking for was how GPs as providers get engaged in the ICS. And then I saw all these other things. Oh, my goodness, there's all these pharmacies and there'll be dentists somewhere, I guess. And it was really just, as I say, nothing to do with the strategy, but more about a question of how these very critical partners in the landscape exert their influence. And I think my main question was about GPs as providers, because they play such a fundamental role. Sorry. Yeah. Oh, well.
Oh. Great stuff. So the delay gives you a chance to think about answering the question. So as a dynamic strategy, one of the things that's emerged over the last year is primary care networks. So we'd already talked about GPs working with charities and social care and others in communities. We call them neighbourhoods, and we think a primary care network in a neighbourhood should be about the same, really, and in many places they are. But primary care networks, groupings of GPs in places of about 50,000 population now exist, and we've got 56 of them. And they think about how you collaborate to deliver stuff, so they are provider groups. And what we've been doing is bringing the 56 primary care network clinical leads together to work through how do they want to engage at a West Yorkshire and Harrogate level. And then within each place, the primary care networks are working with the partnerships locally to make sure that they've got a good voice into the partnership. I think there's a really good opportunity to work at scale with general practice, to do two things. Firstly, to stabilise it, because we need to recognise that in some places general practice is quite frail and it needs some support. And secondly, to make sure that it joins up with all those other services to deliver a different kind of service, which looks at the whole person, is less of a burden to people, and doesn't mean that carers are trying to coordinate care all the time because it's coordinated already. So those are some of the ways. As a proxy before that, before primary care networks existed, we have had West Yorkshire local medical committees represented in the primary community services programme. So that LMCs, which are very good at representing GPs as a providers, have a strong voice.
Okay, thanks for that. Susan?
Thank you. Yes, I think it's much improved from what we saw last time, so thank you very much for all the work you've done. I particularly like the 10 big ambitions, because it has things like, healthy life expectancy, childhood obesity, economic growth, all things that we talked about earlier today. So two questions really. First of all, what do we do with it now? So what kind of action plan, because obviously we need to make these things happen, importantly. And secondly, going back to Helen's question of the previous item, how does it connect with the local industrial strategy, and how are we going to meld the two things? Because there is a lot of commonality, and how do we do that?
Helen, yeah.
I think part of my question is very similar, actually. But there was something for me about reflecting back on the narrative point that was made in the conversation about comms and engagement, and about whether or not, a view from everybody really, whether or not the strategy goes far enough to articulate wellness rather than ill health, when we kind of talk, whether we feel like that's what's been captured by the strategy that we've put forward. But my other part was about kind of how do we now utilise this strategy to actually set that narrative, and how do we work together to distribute it?
We'll work out in the end, won't we? I really welcome the strategy, and I appreciate how much work's gone in to get it to this point. I particularly welcome the 10 themes, and I've shared this both with Rob and Ian, about how I hope perhaps they could be finessed further, that there are shorthands when we're talking about ways of working, whether in our own organisation, in a place, or whether it's a system. And what I'd like to understand more is about how, where we've got work streams coming through and action plans, I'm supporting your point, Susan, but where we've got more work to be done. And I think particularly around the prevention agenda, where perhaps commissioning, governance and funding doesn't really lend us that way, but we all want to work on prevention as well as ill health.
Hello. So I have the privilege of being able to see more than one strategy, and I would like to congratulate everybody in the room for just how much this strategy really reflects both the bottom-up approach from places, but has also drawn from the existing programmes to come up to a strategy that actually is brave enough to put what it wants to do on paper in a way that articulates it in a way that can be understood by the population. This isn't a strategy that's lip service because we had to respond to the 10-year plan. This is a strategy because it's helping us collectively work together, and that's really refreshing to see. And I, for one, have been very privileged and proud to be a part of writing that strategy and then going on and delivering that in the future.
I guess my response was to be almost kind of building on what Rob had said, is that what happens next is what we do next, and what we do next to kind of drive this forward. So an example of that would be around improving population health, that we are looking at doing some work around suicide prevention based upon the suicide audits, based upon the campaign, and some work around building capacity and resilience in communities with those, most of whom aren't known to mental health services. And so I think that there's almost a collective sense of this group being the driving force through a number of programmes, and I think, as Rob said, all of us probably have some role in leading that, would be the sort of a response I'd want to put into it.
Matt, yeah.
So so a bit of a conversation yesterday about how do we get traction on this set of priorities and objectives, and there's just something, whilst we're talking very much about the programmes and their role and responsibility in driving some of this, actually there's a relationship between us as a system and our places, and a conversation to be had about. I suppose it's really how accountability works in terms of our job here and our jobs in our places, and so there's a bit of a story to be told about what the responsibility of each of the places might be, in the same way as we talked about with the industrial strategy, actually. So, and I'm kind of thinking health and wellbeing boards here have a really important role to do some of that knitting together as well. And then it's back to narrative, really. So this, whilst we've worked really hard, and I know we've worked really hard to get to something that is clear and understandable, actually when I take this back to my organisation, I need to do it in 10 minutes. And so I need a way of being able to capture the essence of this in a way that's easy for me to do, and in a way that I am confident is being replicated across the system, because there's something really important about the consistency in the story that we're telling to ourselves and each other.
Okay. Do you want to respond to those points, Rob?
Yeah, I'll respond and bring Ian in if he wants to illuminate further. So I think that the key thing is, what do we do next to make it happen? And the good news is we're not starting from scratch. And what we've got is a series of programmes, places and sectors which are getting on with making improvements, many of which are reflected here, which need to continue. If we draw an example, say, of stroke care, when we did the consultation with people around stroke care, we looked at prevention, we looked at initial emergency treatment, and then we looked at rehabilitation and lifelong support. And on the back of that, and with support from the Academic Health Science Network and the Clinical Forum, we are rolling out, the management of atrial fibrillation in every general practice, so that 9 out of 10 people are managed in general practice, which saves money, saves strokes, saves lives. We have one fewer hyperacute stroke unit, and all of the other hyperacute stroke units have improved their quality. And what we now need to do is to make sure that the offer for people around lifelong support is linked into joined-up care in communities. And the stroke network, which we've created, and the stroke programme will make that happen. And we need to oversee that centrally through the West Yorkshire and Harrogate work. And I could describe for mental health, for the carers programme, for all of the things that we've identified as West Yorkshire and Harrogate priorities through programmes, a plan that is in place, which now needs to be built on and then supported through resources. For things which happen in places, this is built from the bottom up, so Bradford, Colesdale, Kirklees, Wakefield, Harrogate, Leeds, they've all got a place plan and a set of arrangements through their executives. In Leeds, it's the professional executive group, the partnership executive group, and then the providers to oversee the implementation and delivery. And that will be business as usual. The way that the health and care system is gearing up is that the one-year plans that we're going to have to produce, I'm sure, for next year will need to reflect all of those things. So in places, what we'll have is a set of place-based arrangements to deliver your contribution to the plan. And then for people who represent sectors, like Julian here looking at West Yorkshire Association of Acute Trusts, Tom from the the Chief Execs of Local Authorities, there are a set of priorities which fit in there as well, and we need a set of plans. Now, all of that needs to be come together, I think, in a dashboard that we think measures the important stuff. So traditionally, the NHS, or at least since 2001, we've been very good at measuring waiting times for cancer, A&E, operations, and so on. And those are essential things for us to measure. But what we also need to measure is, do people feel in control of their lives? Have they got somewhere to live? What's their healthy life expectancy? And some of the things that we want in our plan. So we need to develop the right dashboard, which we're overseeing through the System Oversight and Assurance Group, which has representatives from everybody here on it, so that it happens, I think, and that oversight group can make investment decisions, peer support decisions, and expert interventions which will deliver the right sort of outcome. So that's what we're gearing up to, and I think we're in a reasonable place with all of that. And our regulators think we're in a reasonable place with all that from the health sector. What we can draw on is the really good experience of councils on sector-led improvement to drive it further.
Thanks, and I think the point that Matt made is really important, which is, it can't just be the work that's happening in the programmes, it needs to be the work that's happening right across the partners. And I guess to an extent that's a choice that you guys have to make in terms of the extent to which you own this in your organisations. And we can absolutely produce a set of slides that you can all talk to in 10 minutes, but the point is that the ownership needs to be there, and people really need to buy into it and understand it. And I guess that's the value of a partnership like this, really.
Kirsten. Yeah.
So I was just going to pick up the point that I think a colleague from Healthwatch and Cathy made, which I do think, without us wanting, camels and committees trying to rewrite it, there's something about the narrative that actually you could attend to. I think your forward could slightly shift and pivot to recognise the work of others like the Combined Authority and LEP and our agency. I mean, the connection with the industrial strategy, the fact that we acknowledge actually the primary thing we can do is work on the social determinants of health. So maybe just shift it slightly, because it comes in quite at a health focus. And then I do think, on the without changing those 10 things, because I think I agree with Susan, it's a great document. Yeah, it's always helpful. I think maybe there's just some of the detail of some of the 10 things could slightly be sharpened to reflect some of the discussion we had today earlier about the strategy and the wider determinants, and refer to them more directly without changing what they are, because I think they're the right aspirations.
Okay. Sorry, yes.
I'd just like to pick up some of the things that have been said about this plan being owned by everybody in the room. As co-opted members, we're very new to the Partnership Board. We're bedding in the same way as you all are. And I just want to say thank you to Karen and the comms team, because I've seen the comments that have been put forward by the co-opted members, and they are all reflected in this. You can see the changes to the document from the input that we've put in. So thank you for that.
Thank you. That's appreciated. Sorry, Julian. Yeah.
Thank you. I won't add to the chorus of approval, but it's good. It is good. I think really, I mean, credit, I think, to the team for segmenting this in the way it's been done. Just one point to zero in on Great Place to Work. Good to see that as a focus. I think we need to make sure we get the support and recognition around the national people plan work, Rob, that you're certainly involved in, and I've had some involvement in. I think the focus that we have, particularly around BME, is really welcome, because we had an excellent session as leaders on that, which Owen sort of marshalled and led us through with other colleagues. And I think that's a distinctive flavour from the Great Place to Work section. But there's also the work we're doing with Mike and the team from HEE, and how, in terms of the doing, we make sure that we've got a collective approach around workforce challenges, workforce kind of redesign, apprenticeships, all the things we talk about, which we've got really good, I think, forward momentum on, just making sure that that's part of our overall kind of focus and ambition in the delivery of the plan.
Okay, I think that probably covers all the comments people have got. Okay. So just remind us, the next stage is very much dependent on timing post the 12th of December now.
Yes, so I think we've got some really helpful suggestions that we can quite easily weave in, and I think we'll try and build on the conversation around the local industrial strategy too. We'll then need to pause and take stock following any formation of a new government and any subsequent guidance, I suppose, but we're keen to get it finalised as quickly as possible. This information goes out of date quite quickly, so we'll be looking to do that as soon as possible in the new year.
Okay, can I just echo everybody's thanks for the work that's gone into getting the document to this stage, and imagine the volume of changes. We all content with that way forward? Thank you. Okay, thank you. And finally, not quite finally, an annual review of the Partnership Memorandum of Understanding. Ian?
Yeah, something completely different, actually, and it was probably a bit of a risk putting this at the end of the agenda, so don't all fall asleep. So we worked quite hard last year to develop a Memorandum of Understanding which described the way of working, what the partnership's about and how it does business. As part of that, we agreed to review it in the first 12 months. and that 12 months came up on us quite quickly, and actually it feels quite soon to be doing this, but we've said we'd do it, and that's what we've done. And so the paper in front of you sets out the kind of the outputs of that review, really, and some recommendations for how we might tweak the MOU so that it's current and so that it's relevant. The overall message is it's a very light touch approach. We're really keen to allow these arrangements to bed in. We know that there may be legislative changes following the general election. So what we've done is we've just looked at whether there's any areas that we can tidy up based on what we've got now. So the approach was done in three ways, really. It was whether there was any learning to date from operating these processes, to see whether there's anything we can do better. It's whether anything's changed since we agreed the document a year ago that needs to be reflected. And then finally, whether there's anything in the NHS long-term plan around ICS working that we thought we might be able to learn from and bring into our partnership way of working. So what the paper then does is it goes through the chapters of the MOU and just suggests any potential changes. So the first section is around the introduction and context, which is what this partnership's about, how it works, what it's here to do. We don't think that changes at all from where it was a year ago, so we're proposing to leave that section well alone. The next section is around how we work together, so the principles, the ways of working, some of the values stuff. There's a couple of areas that we think it's worth just tidying up in line with where we've got to now. So the first one, and to Helen's point, is we probably can do a better job of describing the importance of engagement, co-production, partnership working with our communities. And so if that's an offer of support, Helen, that would be great in terms of tidying that section up. Secondly, we will want to revise the schematic on the priority programmes to reflect those in the 5-year strategy, which have obviously moved slightly. And thirdly, and I think it's been mentioned, we need to strengthen the reference to the role of primary care networks and the importance of GP provider leadership, particularly in these arrangements. So we will do those things. The section on governance, this describes the various groups and boards we've got and how they work. There's two suggested changes there. One is there's a West Yorkshire and Harrogate Quality Surveillance Group, which is a group that's run by NHS England, which takes an oversight of quality and safety issues across West Yorkshire and Harrogate. We just want to make an explicit connection between that and our system oversight group. And we've got the chair of that group now sits in our system oversight and assurance group, so we are making the connections. We just want to reflect that in the language. And we've now put the West Yorkshire and Harrogate Finance Forum on a slightly more firmer footing. We've got terms of references for that, so we'll include those within the document as well. Mutual accountability, again, that section is bedding in. I think we're really getting to grips with that way of working. We obviously had the peer-to-peer review process in Kirklees last week, which is an important part of that. We don't think there's anything to change in the document in line with that. And then decision-making and resolving disagreements. We just want to include within this the way that we worked after the June Partnership Board, where we took the final decision around the 8.75 million outside of the meeting. So we delegated that to the chair and vice chair of the Partnership Board, and that wasn't part of the MOU, but we just cleaned that up. So with agreement from the Partnership Board, we can delegate to other groups if we deem necessary. So those are the main changes. Happy to receive any comments today. Once we've got those, we'll tidy up that document that you've got in your pack, and we'll spin it back out to organisations to sign up to in a way that makes sense for you as organisations. Thank you.
Okay, so a quick summary of the areas of proposed changes, but broadly minimal changes to respond sensibly. Any further comments or views on that? So can I take it that people are happy with that as a way forward? Sorry.
Sorry, I might be missing it, but I think it might just need a little bit of updating in terms of some of the third sector place lead organisations and how they're listed under partners. Yeah.
Make sure that's picked up. Anybody else? Okay, so with that, we're content with that as a way forward. Thank you. Okay, and finally, AOB. So we just ask Rob to update on winter pressures money.
Sure. So in terms of the winter, The media coverage around the state of health and care over the winter has been pretty intense. And in November, the National Director for these sorts of issues, Pauline Philp, wrote to all of the systems to say that could we have a look to see what was going on in each system and provide some assurance around some things which are generally good practice, like making sure you know that GPs are available, what the weekend bank holiday cover and so on is going to be in primary care, the state of your same-day emergency care in your A&E and so on, which was a reasonable set of asks and a reasonable checklist. And as a system, what we welcome that, actually. We said, well, it's better that the regulator works with the system as a whole rather than individual organisations. So on the 22nd of November, at the System Oversight and Assurance Group, which is attended by representatives of all places and includes council and NHS executives, we had an update from each of the A&E delivery boards of where they were against that checklist and where they thought they were in the plan. And as a result, we agreed that we'd do a couple of things to make sure that we were in the right place everywhere for the winter, so that we could ensure services are safe and that people get good care, and if there are requirements for mutual aid, people would get it. Subsequent to that process, there's been an announcement yesterday, or we had a communication yesterday from NHS England and NHS Improvement, which on the one hand is good news, and on the other isn't being done in quite the way we might have wanted it to be. So an additional 2.394 million has been made available to West Yorkshire and Harrogate to mitigate winter pressures. And a national decision's been taken to allocate that direct to some of our acute hospitals. And in taking the decision, I think the national bodies and region have taken account of some of the conversations they've been having with organisations and with systems. So, for example, there's £272,000 for Airedale for additional staffing cover during the winter, which is good, I think. Our preference would have been for any resources to be allocated to the system for us to work together on. Having said that, our approach is that we have a group of acute hospitals which are part of systems and firmly embedded in systems and play a key role in A&E delivery boards and health and wellbeing arrangements. So I've written to everybody to say this money is available, and there's been an outline of what the money should be spent on from suggestions from the national bodies. But we need to make sure that our acute hospitals are working with their A&E delivery boards to look at how the resources are actually spent, and that there's no requirement to spend them all on the things that have been identified, and any slippage or local variation should be managed with A&E delivery boards. So it's good news in a way, but slightly different from the way we would have wanted it to work. I don't know if Julian, as a sort of chair of WIAT, the Association of Acute Trusts, wants to sort of say anything about how it's landed with acute colleagues.
Thank you, Rob. I think just to add to the points you've already made, I think there is, from the centre and those colleagues that have been on the numerous kind of check-up phone calls that we have, I think across WIAT we're very keen to make sure that we do, when we have those kind of interactions, we include our partners in that, because we know that across all of our places, the vital joint working that goes on with social care colleagues, with primary care, with voluntary sector, this is a team effort in every place in terms of keeping patients safe at a time when we're seeing unprecedented levels of attendances and admissions through our ED departments. But that is not just a problem that can be solved within the confines of any acute trust. It's a whole system response required. So I'm sure that in the context of any additional funds, each place will be having the kind of conversations that they'll need to have I think, you know, increasingly many of us are seeing the challenges, particularly around dementia and mental health also, so that's a very important dimension. So I've no doubt that from the perspective and what we talk around the WIAT table and the committee in common about these pressures, it's absolutely recognised this is a whole system approach, and I think that's one that we'll see in the discussions we have as we start to use. And we, I mean, grateful as we are, in the scheme of things, this is not going to move the dial a huge amount for this winter. This is all about the plans that we've got in what we've just been discussing, that we're going to have to pursue with some vigour if we're going to change the way that our patients experience the health and care system currently.
Yeah, thanks. Just with my urgent emergency care hat on for a moment, I think one of the good things to reflect upon is we've been doing some work recently with the both with acute trusts but also with the A&E boards, and we did a stock take of the top 3 challenges for each of the boards, and most of the issues that were flagged up were not directly hospital related. They were to do with social care support, with care homes, with hospital floor, with GP. So I think there's if that's an indication, certainly the feedback is a system feedback via the A&E boards, and I think that's very much the message that we're getting about this winter. Is about we're now in that level of maturity where we recognise there is pressure on A&E, but there's a wider system issue around this. So I just thought I'd take the opportunity to mention that.
It's just to build on some of those other points about this being a system issue. NHS England have made available 1.5 million for the North East and Yorkshire and Humber. But picking up on Rob's point about, I guess, more of a system contribution to the decision-making in that, the difference between the way that the money is being allocated for acute trusts and the way for mental health trusts is that we need to compete and bid for that resource. So I think there is an issue really about, I guess, equity process and the ability, I suppose, for West Yorkshire organisations to get their fair share of that, which obviously we'll be looking at closely. Thank you. Thank you. That was helpful background and reassuring to hear the messages from our acute colleagues about this. Is there anything you want to sum up on, Rob?
I just think Julia made a really good point, really, which is, in the scheme of things, this is welcome resources. It's dwarfed by the money we spend every day. And if we plan together and spend together, we've got a much better chance of managing this winter. I think as a partnership, we've made the case very strongly that all of the resources that will come to West Yorkshire and Harrogate should come up front. So before the start of the year, over as many years as possible, there should be clarity on how much money we're getting through any allocations, how much money we're getting for workforce development, how much money we're getting for capital, how much money we're going to get for transformation, so that we can manage that together. And as we become more mature as an integrated care system, and as the system wants integrated care systems to be successful, I think it's essential that we win that argument.
Thank you. Susan?
Yeah, it's just pointing out the obvious, really, in that winter comes every year. And therefore, if we can perhaps use the next few months to package together what we would think would be a good use of national government winter pressures money, perhaps we can present that to them well in advance in the summer, for example, and then when they come to try and find some money in November, we say, well, this is something we prepared earlier, so they know what we've got and we know we're all signed up to it, and they invest in that. So just a plea really to the work you're doing now, if you can think about it for next year as well, and make sure it's system-wide funding that we're pitching for. And then, as I say, when they've got the money, they can spend it in the right way, on a way that we would all sign up to anyway.
Thank you. Point well taken, I think. Tom?
Just to strongly support that. And I also wonder whether we might have a think about, if we did get that situation where we got that more decentralisation, I guess, at the start of the year, what process we would go through to make sure that we got to a point of an inclusive position, but also one that was that enabled us to prioritise. Because that's, I think, the current structures are working pretty well, but if we got that extra responsibility, we might need to think a bit harder about how we might get to that point.
Okay. No other comments, Rob? Anything you want to add? Or?
No, I think the only final thing I'd say, just to give Suzanne some reassurance, really, Councillor Hinchcliffe, we do try and build on the work we've been doing previously. All of our work to date had built on our experiences with the acceleration zone and other fairly successful schemes. We don't always get to the outcome that we wanted to. I wouldn't want this partnership, though, to be in a position where we're being a bit sniffy about being given extra money. And I think we're slightly in danger of doing that. I think what we are doing... we don't have to be grateful, but I think there is something about... There was a very clear and strong message that there wouldn't be any extra money. And I think it's probably the case that there's been some pain inflicted elsewhere to make sure we got some extra money. So we need to make sure that we spend it in the right way.
Okay, thank you for that. I haven't been notified of any other business. So I can just say thank you to all of you for your attendance and your contributions. And thank you particularly to those colleagues who've worked behind the scenes to make this meeting operate. I know how much preparation there has gone in. We don't meet again until March, so those of you who don't see, I wish you a suitably restful and successful Christmas and New Year, and look forward to seeing you in 2020. Thank you.